when we look at his profile, we see that he has a convex lower third with the upper and lower lips a little bit protruded compared to the chin. Now, what is supposed to be? So the intraoral examination shows a huge overjet, a class 2, okay, and a very, very severe deep bite, So, and the cephalometric analysis shows an obvious bimaxillary protrusion, proclination of the lower incisors, proclination of the upper incisors, and the upper and the lower lip are a little bit more protrusive than we orthodontists. If we stick too much to the cephalometric values, they're a little bit too much than what we like them to be. The MPA is at 105 and the upper to the lower incisors is at 110 degrees. So what is the treatment plan? On the panoramic X-ray, there's actually nothing to deviate from the normal. And what is our treatment plan? Okay, now this is the question. If we stick to the cephalometric analysis, we stick to the hard and soft tissue, and we'd like to resolve the huge overjet and the proclination of the upper and the lower incisor, the treatment plan, the usual conventional treatment plan would be as follow. We extract the 4 first premolars, we bond upper and lower dentition, we align and level, and at that time I used to bond bidimensional MBD technique, which is 18 slot on the upper 4 anterior teeth because I want to control the torque, okay? We retract the upper and the lower anterior teeth on microimplant anchorage. We retract the lower dentition, we close the space, we increase the torque. So that's the conventional way of treating bimaxillary protrusion. And this is what I did. We micro-implant to retract to 4 anterior, as close as possible to the center of resistance of the 4 upper anterior teeth. And after that, we close the upper and the lower spaces by using 1825 stainless steel on the upper. Since I'm using a bidimensional technique, I want to control the torque of the upper 4 anterior teeth. And after 26 months of treatment, I closed all the upper and the lower incisors. I achieved class 1 molar and canine, corrected the deep overbite, corrected the huge overjet. And this is the cephalometric analysis at the end. Now, if I want to critique myself, the position of the upper and the lower incisors is actually very good. This is according to the norms. Lower incisors are well positioned. IMPA is very good. Interincisal angle between the upper and the lower is really good. And I see that the profile of the patient, the upper and the lower lip, have retracted really well. So if I judge my treatment only on the ceph, I'm going to say to myself that, well, Bilal, you did a good job. Okay, this is the panoramic X-ray. And if I even look at the smile is from a alignment point of view, the smile is acceptable. Now, what I don't like about the smile is that it's a flat smile. Okay, patient now after the treatment is showing less incisors than he used to show at the beginning of the treatment or before the treatment. And to make things a little bit more complicated, look at the profile. After 26 months of treatment, which is a little bit shy than close to 2.5 years, look at the patient's profile. Okay, we started with a slight proclination of the upper and the lower lip. And we started with a retroclination and retrusion of the lower jaw. Now, with the growth, the patient's menton and lower jaw grew a little bit. His nose grew a little bit more than the average. And at the age of 16.5, when I completed the treatment, the patient has now a flat lower facial third. And he's only 16 years and a half. So I'm only contemplating, I'm only thinking, I'm only wondering what's going to happen to this patient when he's 26-years old. We know from a lot of studies on soft tissue growth and analysis is that soft tissue menton and soft tissue at the tip of the nose are going to grow more when the patient grows older. So this patient is going to go into a concave type of lower facial height. Okay, so let's talk a little bit about extraction. Was extraction the right decision in this particular patient or not? There's an original article that was published in Angle Orthodontist where the people who wrote this article, they said that there's no difference between the soft tissue in class 2 division 1 cases, whether we extract premolars or we don't extract premolars. And I'm a little bit skeptical about these kind of studies. Why? Because when they do the research, they measure the soft tissue 1 year or a couple of years after the completion of the treatment. But they don't measure the soft tissue. They don't compare the soft tissue of the patients who did extraction and non-extraction 5 years or 10 years or 15 years. And we know that after 1 or a couple of years, there isn't a big change in the soft tissue, but this happens over a period of 5, maybe 7 and 10 years. And what they did during their description of this study is that for the patient who underwent 2 upper premolar extraction, they retracted the upper anterior teeth on 1825 stainless steel in a 2228 slot. Well, I have to stop a little bit here and think. I used in the previous case that I showed you, a case where I extracted 2 upper premolars and I used an MBT bidimensional technique, and it was very difficult for me to control the torque of the upper incisors. Now, in this study, and I'm not saying that the study is not done well, I'm just criticizing the method because we have to be a little bit more skeptical. We have to scrutinize and dissect a little bit the methods when we read a study. They said that they retracted in the extraction cases, they retracted the upper anterior teeth on 1825 and a 2228. And we all know that even in conventional brackets, the twin brackets, even if you fill the slot with 1925, you lose a lot of torque. So now I'm not convinced that on all the patients, there hasn't been any difference in the soft tissue profile change between the extraction and the non-extraction. And not to forget, this is a very important subject that we sometimes forget. Patients, when they come to us after 10 years of extraction or orthodontic treatment, and we did upper premolar and lower premolar extraction, and we asked them to do a panoramic X-ray, on 60% of the cases, like it's written in this paper, we're going to end up asking them to remove also third molars. So if we do extractions in class 2 division 1 cases, this is not guaranteed that we're going to preserve all the other 28 teeth. We might ask the patient to go for extraction of third molars. So when the patient is 25 or 22, even less, he's going to end up with 8 lost teeth. So this means that we have to really be very careful about our choice of extraction. So, but now, are we going to keep on practicing orthodontics the same way that we did before? I think not, because we have a lot of knowledge, we have a lot of information. What do we do now? What do we know now? And I invite you to read this very important and illuminating article written by Patrick Turley in the AJODO in 2015, when he talked about the evolution of aesthetic consideration in orthodontics. And I'm going to choose some paragraphs to read to you. And he said that during the Charles Tweed era, Tweed's philosophy of extracting premolars and uprighting the incisors was well-founded in the treatment of patients with marked bimaxillary protrusion. However, he determined that optimal facial aesthetics depended on having the mandibular incisors at 90 degrees. Okay, this is the Tweed era. But, and Patrick Turley talks that as these patients aged and were recalled for post-treatment examination, the routine extraction of premolars began to be questioned. The post-retention research by Little et al. At the University of Washington showed that patients who started with crowding often had the crowding return. So this means that whether you extract or you don't extract, the stability or the question about the stability is the same. And those patients, most of them were missing 4 premolars and also missing 4 third molars. And this is what I'm talking about. We ask the patient to extract 4 premolars because we want to resolve the problem of the crowding, and we want to resolve the problem of the bimaxillary protrusion in some cases, but we end up asking him to remove 8 teeth. So Tweed's approach has been overused, resulting in many patients looking bimaxillary protrusive. Why? Because now we have longitudinal studies that we can study our cases for 10, 15, and 20 years. Now, What about the aesthetic consideration? Studies have shown a close association between orthodontic anterior tooth movement and lip movement. I cannot understand how retracting the upper anterior teeth 4 to 5 millimeters is not going to have a negative effect on the lip. On the contrary, the lower lip and the upper lip are going to retract, in effect, to retraction of the upper maxillary and mandibular incisor teeth retraction. And long-term studies have shown that after treatment, the soft tissue profile continues to flatten. So be careful when you ask for 4 premolar extraction in a slightly protrusive adolescent case, adolescent patient who's going to go through aging process. We don't want to judge our treatment plan only a couple of years after we finish the treatment. We have to give that patient a beautiful aesthetics for 5, 10, 15 years to come. Peck and Peck attempted to further address the public attitude. So what do lay person and people think about aesthetics? And lay people think that a little bit more protrusive profile is more attractive and more aesthetic. Now, we cannot talk about aesthetics if we don't also mention all the studies and the articles published by Dr. David Sarver. And he showed that there's an interaction of hard tissue, soft tissue, and growth over time. And he stated that, you know, the philtrum, the commissure height is going to decline over years. And he showed that the incisors, upper incisors at rest in males and females is going to diminish over years. So, and also, the gingival display is going to diminish over years, which means that patients age. We all age. We have to think about our treatment plan that we do at age 14 or 15. How is the patient going to look when he's 25 and he's 30? And we owe it to our patients to give him the best aesthetic result possible. And look at this patient. This is actually a case shown by Dr. Sarver in his article. This is an adolescent patient from the age of 14 till the age of 24. Only in a period of 24 years, this patient looks like he's 45 years old. So we have to be very careful on the kind of orthodontic treatment planning that we decide to do. Let's think aesthetics, and let's think how this case will end up in a beautiful result from an aesthetic point of view. Now, this is a very important study that's been published in the American Journal by Bjorn Zachrisson, and I was actually shocked on the results of the study. Ideal lower incisors in ideal patients having beautiful aesthetics were more proclined 2 to 3 millimeters lower incisors on the APO line. None of the lower incisors in all those beautiful cases that don't need any kind of orthodontic treatment, none of those lower incisors were flat dead on the APO line. All of them were more proclined. So now, from an aesthetic point of view, we know now that people, lay persons, like more fuller profiles. And from the hard tissue point of view, which is the lower incisors position, beautiful faces also have lower incisors more proclined than we thought from the Ricketts, Tweed, or Steiner analysis. So we have to start, diverging a little bit from those dogmas, from this guideline of 90 degrees, because we know now that if you place the lower incisors at 90 degrees, we don't guarantee beautiful aesthetics for the patient. And what do the patient want? When the patients come to our clinic, what do they want? The first and only thing that they think about is facial attractiveness. They're not going to come to us saying, "Doctor, look, I have my lower incisors at 105. Please, can you make them at 90 degrees? No, they don't know about that. They don't think about that. What they want actually is to look like this. They want to look beautiful. They want to have radiant smile. They want to feel that when they step into a room with colleagues, with cousins, with friends, they want to own the room. They want to have a smile that can captivate all the other people surrounding them. They want to look like this. And in those, celebrities pictures that I showed you, none of them is actually showing lower incisors. Nobody really wants to come and care about lower incisors. But here I open a parenthesis, and I'm going to tell all of you, my fellow orthodontists, is we need to think about where to position the lower incisors. I'm not saying that we just align the upper teeth, make them beautiful, and we don't take care of the lower incisors. This is not what I'm saying. What I'm saying is that what's important for the aesthetics is not the lower incisors. So my protocol is always to look at every case from the outside in. This is what Dr. Sarver talked about, the macro aesthetics, the mini aesthetics, and the micro aesthetics. So we look at the face, the aesthetics, we look at the smile, we look at the front teeth, and we look at the shape, at the embrasure, at the size and the shape and the color of the teeth. And I like to simplify the protocol and use only one prescription. And when it comes to retention, since the studies of Little have shown that there's always a relapse and there's always a question on stability, whether it is extraction, non-extraction, I always preconize to my patient fixed upper and lower retention and removable upper and lower retention for as long as the patient can keep those retention in place. And I'm going to show you one of those cases. This is how I do treatment plan now, how my mind is aesthetically oriented to give the patient the best aesthetic possible. So this is a 14-year-old boy who came to the clinic and he said, look, doctor, my upper front teeth are sticking out. And we see that he has a V-shaped upper arch. The upper arch is constricted on the upper premolar and molar. Okay. He has a huge overjet of almost 8 millimeter. A severe class 2, full class 2 on the left side, and half cusp class 2 on the right side, with no crowding on the upper, almost, like very minor crowding on the upper and moderate crowding on the lower. But wow, if we take a look at his ceph, okay, look at this huge overjet between the upper and the lower teeth. He can barely, seal his lips to be able to close his mouth. And look at the severe curve of spee on the lower. So for the first impression, how am I going to treat this class 2 division 1 with this huge overjet? Well, since he's 13 years old, I'm going to try to rely on the growth. I want to position his mandible forward. Why? Because I think that the position of the upper incisors actually is slightly protruded and not excessively protruded. Okay, this is what I see. This is his panoramic x-ray, and I just simulate on PowerPoint how if I just cut the mandible and advance the mandible forward, this patient on this initial pictures will look much better in the profile wise if I move his mandible forward. Now, would the mandible move forward? Would the growth, will his growth help me? I'm gonna see. So I started with fixed appliance on the upper, and I asked the patient to wear class 2 elastics, but he wasn't that cooperant with the class 2 elastic. So on the class 2 side, I used a fixed functional appliance to correct the asymmetry in the mandible, push the mandible forward, and try to achieve a good class 1 canine and molar. Okay. And with the use of this fixed functional and with the use of class 2 elastics, I was able to correct the overjet, but the problem is the maxillary occlusal plane tilted downward in the anterior part, and now I see more gingiva. So yes, I corrected the class 2. He has a class 1 canine and molar. I've corrected the overjet. He has now an acceptable overjet and overbite. The mandible did not move so much forward, so it seems that his growth is not helping a lot. But I corrected the class 2, but I made his aesthetics a little bit worse. When I take a picture, I don't like what I see. So look at this. Okay, there's a tilt downward of the upper anterior part of the maxilla. I cannot leave him like this. I cannot tell him that, look, I corrected your class 2. You wanted your teeth, your upper anterior teeth that are sticking out, you want them back. So this is what you asked for. I gave you this, but what about the aesthetic result of the patient? I cannot leave him like this. So what I did is I added 2 anterior micro implants in the anterior part, and I started intruding and trying to reduce the gummy smile as much as I can. And while doing that, I was asking the patient always to follow with vertical elastics the mandible so that it can always occlude with the maxilla. And after a period of time, we finished the case and look at the aesthetics. Now I can say that this case was beautifully done. Why? Because I corrected the class 2, the overjet, the severe curve of Spee, and when the patient is smiling, he shows beautiful upper 10 teeth with vertical incisal display of 100%, no gummy smile. Did the mandible go forward? Not much. Did his upper lip drop? No, it did not, because it's a short lip. Okay. Did his chin go forward? No, it did not. But when he looks at himself, when he sees his smile, he's very happy. And this is the occlusion. We got a beautiful class 1 on this side, and 90% correction of the class 1 on the canine, beautiful upper incisor display, and the lower incisors did not have to be compensated too much. Okay, because we have to compromise on something. And in class 2 division 1 cases where the mandible doesn't grow forward, lower incisors procline. But in this case, you know, with proper biomechanics, you can try to control the proclination of the lower incisors. And look how he was before and how he is now after the completion of treatment. Look at his smile before and look at his smile now. So would it be a big mistake if I went for upper premolar extraction? Of course, it would be a big mistake. Why? Because instead of moving the mandible forward, I brought the maxilla backward. So, and I could have ruined completely his smile. Did he grow? No. Did his mandible grow? Not much. So I was able to save the smile. Okay. And if the mandible did not help me, well, it's not a big deal. It's not a big deal. And this is 1.5 years follow-up. He still have a beautiful smile. Now we can see a little bit of growth, okay, in the mandible, in the button of the chin, but I gave him a beautiful smile, and I think it would have been a great mistake to extract upper 2 premolars just to correct his class 2 division 1. Let's take another example. This is a 14-year-old girl who came for a full class 2 on both sides with a V-shaped upper arch and narrow upper arch and an overjet of 7 millimeters. But if I look at her profile, you know, her smile is canted. But I like the smile. Why? Because she shows a lot of upper incisors. She shows a lot of white. And this is what I like at the end of my patient's treatment. Okay, she shows from premolar to premolar. What I need to do is I need to correct the class 2, but I need to preserve the smile. I need to correct the cat and correct the class 2. So look at this overjet. Okay, a huge overjet. But the profile, the soft tissue profile, is acceptable. So is it an extraction or non-extraction case? I prefer to do this case non-extraction. So while bonding the upper and the lower arch, we started with very light class 2 elastics, and we used some bite ramps to guide the mandible forward. Luckily, the patient was able to posture the mandible forward, and a lot of class 2 division 1 cases, whether they are growing patient or non-growing patient, I believe in the repositioning of the mandible. We can reposition the mandible forward, and we can preserve the contact on the first and the second premolar, because there are excellent elements for the stability of the bite. And look at the final result. She has a beautiful smile. She shows all the upper incisors. She shows a 10-tooth smile. And I preserved the soft tissue profile. Now the soft tissue profile is a little bit protrusive for her age, which is good. And it's not convex, it's not flat. But I know that this patient, when she's going to grow, she's going to preserve her beautiful aesthetics. And look at this nice profile. And this is just the Ceph just before debonding, okay? Good position of the lower incisors and the upper incisors. So this positioning of the mandible forward was able to help me preserve the aesthetics, correct the class 2 division 1, which is a full step. Okay, and look at this beautiful aesthetic smile at the end of the treatment. Let's take an example of a class 3 case. This is a 14-year-old girl who came to the clinic because she felt that her mandible needs surgery. Okay, I know that if you look at her profile, of course, the mandible is strong. She has a very strong chin. But what I like about this patient is just this beautiful curl of the upper lip. And I know when I look at all my patients from the outside in, so I look at their face, I look at their smiles, I look at their lips, how thick are their lips. I want to keep this beautiful curl. Why? Because if the mandible grows a little bit more, okay, and I do a treatment in a way that I remove this curl, I'm going to mess up the profile of this patient. Now, when it comes to the smile, I'd like her to show more teeth. Why? Because in class 3 cases, class 3 mechanics tend to procline the upper anterior teeth, retrocline the lower anterior teeth, correct in those kind of mechanics the class 3 problem, but it's going to procline the upper incisors. And the more we procline the upper incisors, the less they show. So in a couple of years, if I correct the class 3, but I don't pay attention to the position of the upper incisors, they're going to end up flared. And when she smiles, she's not going to show her upper teeth. She's going to be 16 years old, but she's going to look like 36 years old. So that's her smile. And we have a severe crowding on the upper edge to edge, and it's a clear class 3 skeletal case. So what did I do? I used a passive self-ligation, expansion, very low expansion, development, enlargement of the upper arch, very low force coil spring to make space for the blocked in lower incisors. And what I did is I flipped the upper incisors bracket, the 4 upper incisors bracket, I flipped them upside down 180 degrees, because instead of getting the plus 14, I get minus 14, so I can upright the upper incisors while I'm using class 3 mechanics. And after a period of time, this is the end result. You see the beautiful torque on the upper incisors, correction of the class 3, and beautiful enlargement of the upper and the lower arch. So this is how we started. This is at the beginning of the initiation of the orthodontic treatment and bonding, okay? And this is the final result. And on the lower, it's the same thing. And look at the final result. I would have liked to extrude the upper anterior teeth a little bit more, but she has a little bit of drop in her philtrum, which makes the upper incisors not show 100%, about 50%. But look at the curl, okay? Her mandible grew a little bit more during this 2 years, and the chin button also grew more, but we still have a positive position of the upper lip compared to the lower lip and compared to the chin. Okay, so was this a surgical case? It could have been if the patient comes to me and says, look, doctor, I want to change the shape of my chin. I want to change the shape of my lower jaw. We could have done this treatment, okay? And at the end, she could have done a genioplasty just to reduce the position and the size of the chin, because I think that the position of her upper incisors and her occlusion is quite acceptable. Okay, so now let's talk about a different kind of orthodontics, about missing teeth. Okay, this is a 15-and-a-half-year-old girl, and she says that I don't like my smile because something is wrong. And upon examination, okay, I see that she's missing tooth number 12. And we started this case in November 2018. Okay, she's missing tooth number 12. She has the upper 13 in the place of the 12, and she has a persistent upper right primary canine. But on this side, the left side, everything is okay. The occlusion is fine. We have some spaces. Now, what kind of usually treatment do we do for cases that have missing teeth? Okay, so either we open space, so we retract the canine backward, we extract the C, we retract the canine backward, and we position an implant when she's 18 or 19. And we end up at every 5 to 10 years changing the crown, because we all know that there's always a vertical growth in the bone. So we get caught up in a vicious circle of prosthodontics. Okay, that's option 1. Option 2 is that we keep the canine where it is. Okay, we do some kind of coronoplasty for it, so we can change it into a lateral incisors, and instead of the canine, we do an implant. Okay, that's the fastest, most reliable treatment, because we're not closing any spaces, we're not opening any spaces. Okay, we just substitute the canine for another canine with implant, but we have to wait another 3.5 or 4 years to be able to do that. And this patient and her parents wants me to do something at this age. The third option is that, okay, we extract on the lower arch, okay, and we extract another premolar on the upper left quadrant, so we can balance the number of teeth. We close the spaces on the upper, we close the spaces on the lower, and we consider that this has been a 4 premolar extraction. Okay, and our last treatment option is to extract the C and move everything forward. And this is what I chose. Okay, why? Because she has a beautiful inclination of the upper and the lower incisors. She has a beautiful upper and lower lip position, and I don't want to change that. So now the challenge is, when we extract the C, is to protract everything forward. And we have to do it in a way that we don't lose any kind of anchorage and we don't deviate the midline. So I've used TADS in this case to protract the whole upper right segment forward. Okay, so we closed about an 8mm space, and we placed also an infrazygomatic screw on the upper left side so we can stabilize the canine premolar occlusion on the upper left side. Okay, and we continued on closing the spaces on the upper right side. And this is just before the debonding. Okay, we do some coronoplasty for the canine, we remove the tip, we round the buccal surface, and just before removing the braces, we make sure that all the spaces are closed, the midlines are on, and we send the patient after debonding for some kind of build-up and recontouring, and we end up with a beautiful smile, beautiful occlusion, and we didn't have to go to any kind of implant or prosthetic replacement for the missing tooth. And look at her smile. Now, if you look closely, you're going to find a little bit of discrepancy between the right and the left side, but we made it in a way that either you are a trained orthodontist or a trained restorative dentist. Otherwise, you're not going to be able to find that there's something different between her upper right and her upper left maxillary quadrant. Look at this beautiful smile arc, the incisor display. So we chose the right treatment plan for this patient when it comes to aesthetics. She's happy, she's very confident, and we did a treatment plan that suits her aesthetics. Okay, so, and I'd like to thank also the restorative dentist who did a great job when it comes to build up on the canine and the premolar. Okay, and I'm going to show you also a very, very interesting and awkward class 2 division 1 case. He's 13 years old. He barely wants to smile. Okay, he barely wants to smile. Why? Because he's not confident with the proclination and the protrusion of his upper front teeth, and they're so proclined that when he smiles they don't show, because I've told you the more you procline the upper teeth, the less they show. But when you look at his profile, he doesn't have actually a class 2 division 1 profile. He has a balanced upper and lower lip, a slight chin button which is a bit strong, but he doesn't have a retruded chin. But when we look at his intraoral photograph, he has a missing lower fives, persistent lower E's. Okay, look how huge the E's are, severe crowding on the lower, and a huge overjet with proclined upper anterior teeth. Look at his overjet. Look at his proclination of the upper incisors. Okay, definitely, this is an extraction case, and I'm not against extraction, but I'm a little bit worried that if we extract and we retrocline the upper incisors, what's going to happen to his lip? Already the lip is almost flat. Already the lip is not protrusive. We already have a lower incisor third, which is flat, and he's only 13 years old. Is there any way, any other way that we can do this treatment without further retroclination and placing his profile in the future at risk? Okay, so I decided with the parents that since his lower E's are in a good position, they have good roots, okay, and he doesn't have third molars, so let's try to keep them, and let's try to expand the upper arch. Let's try to enlarge the upper arch so we can create space to retrocline the upper incisors, okay, and correct the lower crowding. We can procline them a little bit, because definitely we have to think about this case in a compromised way if we don't want to extract. In case we need more space, we can do some interproximal reduction. So I'm going to use everything I know in orthodontics, from enlargement to IPR to class 2 elastics to posturing the mandible forward, in order to keep this case away from the extraction. Because the regular pattern of extraction of treatment planning in this case was, because I have a severe overjet, I would extract 2 upper premolars And it would be okay also to extract the lower E's. So it's a 2 upper first premolars, 2 lower E's. I would close the space, okay? Use class 2 elastics to try to move the lower molar forward, okay? And I would have probably done the patient a service because I've ridden him from future implant in case the lower E's fall off. But I wanted to just try to preserve the position of his upper lip because I wouldn't know how this patient is going to develop from the aesthetic point of view when he's 25 years old. And I managed well to expand the upper arch, create space, use IPR even on the lower E's so I can, create space to correct the lower crowding. And this is how we ended up after 2 years of treatment. Overjet is completely corrected. The midlines are on. Beautiful class 1 on the right. Good class 1, not so 100% on the left side, but beautiful torque on the upper and the lower incisors. Nice expansion of the upper and the lower arch. And look at this ceph at the end of the treatment. When I took the ceph, I was really shocked. Look at the incisor, upper incisor inclination, lower incisors inclination. It's really good when it comes to the position of the lower incisors compared to the mandibular plane, okay? Lower E's, they held on very good to the orthodontic treatment. Beautiful uprighting of the upper and lower molars and canine. I couldn't be more happy. Why? Because I did this treatment, which is a huge overjet, excessively protruded upper incisors, and severe reverse curve of P in the lower. I was able to treat this and look at the situation of his upper lips. Okay, look how he was before. Look how he is now. His lips are more relaxed. They have a curl. They go more with his face. And look at the smile. Before, when he was smiling, he couldn't smile. Why? Upper teeth are too much proclined. They don't show. But now, after retroclination with no extraction, he shows all his upper teeth. He's very happy. He have a beautiful smile arc, and we preserve all his teeth. And just to show you that sometimes, ceph analysis, ceph x-rays are so much, misleading. Why? Because this case came to me and the patient said, look, doctor, I visited so many orthodontists and they all told me that I have to go through orthodontic surgery, but I don't care about my chin. I know that I don't have a chin. I know that I have a very small mandible. What I care about is I need a more, attractive smile. I need my upper front teeth not to stick out too much. And I told him, when they told you that you need extraction and surgery, they were right. What do you want me to do? We orthodontists, we have a positive influence on the face, but in your case, you need a lot more from the orthodontic treatment. And he said, whatever you need to do in order to give me a better smile, I can go for it. And I told him, we're going to start this case by aligning the teeth, trying to expand the upper arch so we can create space and take this proclination of your upper teeth and bring it backward into the expansion space that we created. And look at his ceph. Excessively proclination of the upper and the lower incisors, okay? This is definitely an extraction and an orthodontic surgery case. But after 2.5 years of treatment, we used micro implants. We expanded the upper arch. We expanded the lower arch. We used some kind of IPR on the lower. And look at the beautiful expansion of the upper arch. Look at his solid class 1 on both sides, on molars and canines. And look at his smile. Okay, he's a totally different person when it comes to smile. Patients don't look at themselves from the profile. Now with the mania of the selfie, they take selfies of themselves maybe 10, 15 times per day, but they take it from the front. And this treatment gave this patient what he wants. He changed how he looks at himself, and we gave him a totally different smile. His chin, of course, because we had to use micro implant, we intruded the posterior teeth a little bit, so his chin moved forward, but still he needs genioplasty. Probably he needs more than that to have a beautiful profile, but he's very happy. And when it comes to ceph, if I show you this, well, you say, well, Dr. Bilal, there hasn't been any tremendous change. between the before and after. Before, his teeth were procline, okay, but he had an overjet. Now he has upper and lower incisors procline, okay, they're protruded and procline, but he doesn't have an overjet. I'm saying yes, but look at the difference in the smile. Not everything that looks on the Ceph bad looks bad on aesthetics. And I think that this patient is very happy from the aesthetic point of view. Look at the broad smile that we gave him. Look at the broad smile and look at the before and after. And this is completely different. This is completely. If I would have based this treatment on just the Ceph and extracting the teeth, I would have done the conventional way, and it's right. And I give it to you. It's not bad. It's not wrong. But what about his profile? He would be completely concave profile, okay? And if we need to do any kind of extraction with any kind of orthodontic surgery, if he decides to do that later, we can always do that. So in orthodontics, we used to base our diagnosis and treatment plan on the position of the lower teeth. But 25 years ago, Dr. Thomas Creekmore wrote a beautiful paper in JCO, and he said where teeth should be positioned in the face and jaw and how to get them there. This is 25 years ago. And he said optimum positioning of the teeth in the face should be predicted on the position of the maxillary incisors rather than on the position of the mandibular incisors. And the maxillary incisors should be at 5 millimeters plus or minus 2 millimeters and 22 degrees plus or minus 5 degrees to NA for all skeletal patterns. So we should try to position the upper incisors on those norms, regardless of if it's class 1, class 2, or class 3. Why? Because the position of the upper incisors is the criteria to a beautiful smile. And according to that, we position the lower incisors according to the maxillary incisors and not the other way around. If we want to give our patients beautiful smiles, let's take care of the position of the upper incisors and we fit the lower incisors to that. In conclusion, whether you do extraction or non-extraction, it's not a problem. That's not the issue today. If you follow evidence-based articles, remember that your patients do not always fall within the average of the study. Whether you like conventional braces or you like self-ligation, it's not the issue. If you follow a certain guru, a certain master in orthodontics, okay? If you like to use aligners, if you do surgery, what I advise you to do is always to individualize, try to individualize the treatment plan of your patient so you can give him the best aesthetic result possible. And for that, I thank you so much for listening to me, for giving me the time to show what I have in my background. And I'm open to questions now if you have any questions. So let's see. Okay. I also believe, for Sina, I also believe in the possibility of mandibular repositioning. Thank you, doctor, for this beautiful case. Wonderful lecture. You're most welcome. I just kindly ask you for more info on your working protocol and facial profile and tissue analysis you are doing for every patient. Okay, I guess this is a long question. We can do it probably in another webinar. Marie, will positioning lower incisors according to upper incisors position compromise stability? Excellent question. Excellent question. I always take into consideration the fact that can I advance the lower incisors in a way that I can keep them in their bony housing, okay? And whenever I have a doubt on the thickness and the type of bone surrounding the lower incisors, I always take a CBCT to be sure that I can advance those lower incisors or not. Sahin, thank you so much. Thank you. Thank you for attending today's webinar. Sir, do you publish these as case reports? Not all of them. Nice presentation. Thank you. What about the stability of mandibular advancement in adult patient? You can always advance the mandible even in non-growing patient for 2-3 millimeters to help correct your class 2. Okay, and the stability always comes from a beautiful and good interdigitation between the premolars. That's very important. Okay. Thank you for this, Talar, for this amazing lecture. Thank you so much. My question is, why did you use the synergy bracket in some cases? Do they have any advantage? No, at that time, I used to use synergy brackets. At that time, I thought that they have some kind of advantage because I can ligate in a different way. Now I'm 100% passive self-ligation. It was a nice presentation, sir. Torque is going to be tricky in class 2 cases. What torque value can be used? You know, torque is a very important subject to me, and we know that from a lot of studies that you lose a lot of torque. So you need to be sure that the system that you're using, the system, I mean by system, brackets and just a second. Brackets and wires, you need to make sure that they fill the slot and then you don't lose a lot of torque. Now, if your system makes you lose torque, then either you have to add torque to your wire, or you can use auxiliaries to add torque like Warren springs or anterior root torquing springs. How do you maintain retention? Fixed retention upper and the lower full time, and removal retention during the night. What is the thickness of the essex? It's 1 millimeter sheet, and after you vacuum form it, it becomes 0.75. As you mentioned that PSL can expand arch a lot, I have a question whether it will relapse in the future. There has been studies that there you have some kind of relapse in the premolar molar area, but we always try to enlarge with round niti, round thermal niti. And round thermal niti, when you use them with passive self-ligation, they don't give you more than 20 grams of force per 1 or 2 millimeters. So what we do is we try to lower the force of the enlargement so we can get stability. What situation do you still use conventional brackets? I've stopped using conventional brackets. I'm more comfortable with the self-ligation, but you use whatever you feel comfortable. Thank you for this wonderful lecture, Dr. Bilal. I have a question regarding the bracket positioning. Do you have any specific formulas for positioning the brackets on certain cases? Yes, when it comes to the most important thing for me is positioning the brackets on the upper anterior teeth. And I'm not afraid to go, you know, like 6 millimeters, 7 millimeters on the upper centrals from the incisal border, because I want to make those upper teeth, you know, look full. So I position according to the smile. What is your opinion about lower 4-to-4 fixed retainer? I use them on a lot of occasions. They're fine. How do you decide on the expansion limits? The expansion limits is always what the 14 and the 18 thermal niti give me. I don't go beyond that. So when I leave my 14 niti, and after that my 18 niti for the first 4 or 5 months, this kind and limit of expansion is what I get. I don't go beyond that. Okay, I don't try to expand my arches with heavy stainless steel arch wires because then it's not stable. How do you decide? Yeah, okay. Thank you. Nice lecture. In the class 3 case, was it safe to use inverted brackets on the incisor without risking root bulging? Excellent question. Whenever I invert the upper brackets upside down, I don't go beyond 1725 stainless steel. I don't fill the slot. And during every appointment, I try to palpate the roots with my finger. Can you please explain mechanics used for posterior protraction? So I try to protract using the anterior teeth as anchorage, holding them with a micro implant. Okay, I'll take another couple of questions. Was it safe? Okay, mechanics. I mean the bracket position to create beautiful smile. Yes, I always bond the upper central incisors higher, the lateral incisors 1 millimeter lower, and the canines half or 1 millimeter lower. So I'd like always to have the 2 central incisors more dominant and more showing that the other teeth. Do you think the retention is better with extraction than non-extraction? I think that we have relapse in whatever protocol we use. At our school, they don't like non-extracting because of what they say, bad retention. And thank you very much. It's not me that said that whether it is extraction or non-extraction, you always get relapse. It's the most important study done in the history of orthodontics with Dr. Little. Thank you, great cases. Thank you. Do you use Invisalign? Yes and no, only for indicated the minor cases. Sir, how do I get these case reports? Share links. Sometimes I post cases on Genius PSL. It's a Facebook page that I created just for fun. You can see some cases posted there. Thank you for delivering very informative webinar. Thank you. Thank you so much. And thank you for listening to me. And on this note, I'd like to thank again all the listeners. Thank you for being here, for your beautiful questions. And thank you, WebCephX. Hope we meet soon. Take care and have a nice rest of your Sunday evening.